Hit the subscribe button or visit us at auau.auanet.org.
Good. Well, thank you, Dr. Cookson. And so the recognition that the androgen receptor plays a role in castration-resistant prostate cancer was really a major discovery leading to the development of these agents. And certainly these are drugs that any urologist can utilize, and many do, but they're also indications to be knowledgeable regarding. These are my disclosures, none of which are pertinent. So these pathway inhibitors initially were utilized in more advanced disease, castration-resistant disease, but realize now that they're now indicated also in hormone-sensitive metastatic prostate cancer. So we'll be talking about mechanisms for castration-resistant development. We'll understand existing and new applications for these oral androgen axis agents. We'll understand the mechanisms and side effects associated with these drugs. And then finally, we'll talk about some of the new insights into androgen deprivation therapy and its side effects. So we'll start with a case. This is a 72-year-old with metastatic castration-resistant prostate cancer, a history of biochemical recurrence following radiation therapy for locally advanced prostate cancer. 3 years later, he developed a rising PSA while on continuous LHRH therapy, and his PSA went from 8 to 21 over 8 months, so a relatively rapid increase. It's important to check his testosterone in these patients, and his was indeed low at 19, inappropriate, given the fact he was on ADT. And he now has new pelvic bone metastases with enlarged pelvic and retroperitoneal lymph nodes. So what are the stages and options we can consider for this patient? So the amplification of the androgen receptor is something that occurs very uniformly in advanced prostate cancer. On the left are prostate cancer cells from a lymph node that are shown expressing the androgen receptor or overexpressing it in lymph node disease. And at autopsy, about 73% of samples expressed androgen receptor amplification. Now, it's important to realize that there are ligand-dependent and ligand-independent mechanisms, such as co-activators. We're not going to be talking about these independent mechanisms, but rather focusing on these dependent mechanisms, since most of the drugs we have are directed towards this area. What we can see in the middle here is androgen receptor amplification is one mechanism. The more androgen receptor you have, the more opportunities for ligand to bind to this signaling. In the upper part, we have adrenal androgens and their their use by the androgen receptor, and these are so-called promiscuous pathways in which the androgen receptor can utilize adrenal androgens that are converted through DHT for its use. We also note that there are AR promiscuity that's seen. So these are mutations that occur in the androgen receptor, enabling it to utilize alternative ligands such as glucocorticoids and other metabolites. And then finally, on the right, we see androgen receptor variations or variants. And ARV7 is one we've all heard commonly about. And these essentially are able to bind to DNA and auto-activate it in the absence of ligand. So note that abiraterone affects adrenal androgen production, while apalutamide, darolutamide, and enzalutamide affect AR binding. Now, abiraterone was the first drug that was discovered, and it blocks very strongly the alpha hydroxylase and C1720 lyase activity of CYP17. Because of this, there is an increase in aldosterone and cortisol, and we subsequently see side effects associated with this, including salt retention and low potassium. In addition, there are side effects associated with increased cortisol. Abiraterone is always utilized with prednisone, which can help blunt these effects. These were some of the first trials that were done in both the post-docetaxel chemotherapy space and the pre-chemotherapy space, showing improvements in survival in patients that got these drugs, abiraterone. And again, all of the secondary endpoints, including PSA progression, progression-free survival, and PSA response rate, favored the abiraterone group. So what are some of the side effects associated with abiraterone usage? Well, certainly increased transaminases such as ALT and AST are seen, and it's important to check these routinely in patients we're giving these drugs to. Hypertension and hypokalemia are again found more frequently in this setting as well. So how do we minimize the side effects? Take on an empty stomach, give with prednisone, as we mentioned. Liver enzymes must be checked, as well as BMP must be checked 2 weeks after starting, and then monthly for the first 3 months. And if you get a rise in the liver function tests, you need to hold the drug until these normalize and then restart at a lower dose. Our physician colleagues in internal medicine can help with hypertension and fluid retention in these patients. And remember, there are a number of drug interactions that can occur with these. Now, I mentioned abiraterone, enzalutamide, apalutamide can all be used in this hormone metastatic space. We'll be talking a little bit more about that in the next lectures. So abiraterone is FDA approved in men with metastatic castration-resistant prostate cancer, both before and after chemotherapy, and also in metastatic hormone-sensitive prostate cancer with ADT. Again, side effects: hypertension, hypokalemia, edema, and steroid-induced hyperglycemia. So we want to think about patients that were, for example, brittle diabetics, that had gastric ulcers, that had active infections as being less ideal candidates for this drug, as well as individuals with cardiac disease. You need to be careful also with those individuals with pre-existing hepatic dysfunction and certainly alcohol abuse. So this is just summarizing the abiraterone's use in the metastatic hormone-sensitive and metastatic castration-resistant space. Let's switch over to enzalutamide. And again, this is an entirely different drug, but it functions in relatively the same space. And this was enzalutamide was an orally and rationally designed drug that really targeted androgen receptor signaling in a number of steps. And this includes inhibiting binding to the androgens to the androgen receptor. It includes inhibiting nuclear translocation of the androgen receptor. And then finally, directly blocking the association of androgen receptor with DNA. Apalutamide and darolutamide have similar mechanisms of actions, slightly different side effects, and we'll talk a little bit more about those. So enzalutamide is approved in both the post and pre-docetaxel states. On the left, you can see the overall survival improved roughly 3 to 4 months in the post space. And on the right, actually, we're just looking at radiographic progression-free survival, which was markedly improved in patients that got enzalutamide. Let's talk about side effects that were commonly seen in these patients. Fatigue is something that's significant, and one needs to be careful in elderly patients with regard to this. As expected, hot flashes. Seizures are found at a very low level, but we can talk a little bit more about that side effect. Hypertension is also found in these patients, and they are at increased risk for falls. So again, one wants to be careful in the elderly with regard to this. One has to be careful about drug interactions as well. Gemfibrozil or other CYP2C8 inhibitors may affect the metabolization of enzalutamide. It can also affect the serum levels of other CYP-inducing agents such as warfarin. If there is profound fatigue, one considered dose reduction. Be careful with meds that lower the seizure threshold, such as bupropion, which is utilized for to decrease drinking. So which patients should we use this in? It's FDA approved for men with metastatic castration-resistant prostate cancer before and after chemotherapy, as well as in the M0 CRPC state and in metastatic hormone-sensitive prostate cancer. Again, profound fatigue, hypertension. It can cause constipation as well, so one needs to be aware of that side effects, and rarely some of these CNS effects. Which patients are poor candidates? The elderly, patients who have significant issues already walking, who have significant fatigue, and obviously anyone with a previous history of a seizure. So let's talk about these other apalutamide, which was approved after enzalutamide. There's similar side effects, but again, one's difference was hypothyroidism, so that you need to check thyroid drugs in these patients, thyroid levels in these patients, as well as a rash. Also, darolutamide has a similar mechanism of action, similar side effect. There's some thought that there may be less blood-brain barrier penetration, so there may not be as much fatigue in this drug. So which of these should go first in advanced disease? There's really limited data to guide us. In the CARDS trial, there was data suggesting that Abiraterone before enzalutamide improved PSA progression versus the other way around. But generally, one should, if you fail an androgen signaling agent, should consider another mechanism. There are unique situations with very rapid disease progression, significant symptoms, or visceral disease where you may want to go straight to chemotherapy. And certainly for very aggressive variants, sometimes docetaxel is combined with carboplatin or etoposide cisplatin for neuroendocrine small cell variants. We'll be talking more about that tomorrow. And then obviously there are financial toxicity and challenges that arise. So this is just summarizing second generation oral anti-androgens. Of note, there's been increasing interest in so-called triplet therapy, where you're combining docetaxel with these drugs as well as ADT, and we'll be talking more about that as well. So let's just spend the last few minutes here talking about adverse events with androgen deprivation therapy. We're all very used to hot flashes in these patients. We can use venlafaxine and gabapentin to help mitigate that effect. Osteoporosis, we'll talk more about that. Fatigue, again, exercise may be beneficial in those patients. Metabolic syndrome is something that we'll talk a little bit more about. And then cardiovascular disease and thromboembolic events, I think were foreshadowed by Dr. Borgen's talk, looking at some of the outcomes in patients and with more advanced disease. So certainly androgen deprivation therapy can affect cardiovascular risk factors, including serum lipoproteins, insulin sensitivity, and these patients experience weight gain. There have been meta-analyses of these observational studies that have reported associations between androgen deprivation therapy and greater risks for cardiovascular events and death. They're fairly consistent associations with these GnRH agonists, but they're mixed associations with these GnRH antagonists. And it's important to realize that these studies are not always powered to be able to show a difference in cardiovascular events because they are relatively uncommon, but rather they're obviously more interested in outcomes with the drugs. There was a trial, it was called HERO, where they looked at major adverse cardiovascular events with the leuprolide versus relugolux, which is, again, a GnRH antagonist. And that demonstrated a slight advantage to the oral agent. In contrast, when you look back at these pooled trials from randomized controls, there are minimal differences in the cardiovascular risk profiles. There was a trial PRONOUNCE, which was randomized, looking at cardiovascular safety and they really found no difference in cardiovascular events between antagonists and agonists. So I think in conclusion, there's relatively little differences there. Finally, it's important to make sure that in these patients we completely evaluate their cardiovascular status. And in about 30% of U.S. veterans with prostate cancer, 30% they do not routinely get comprehensive cardiovascular assessments. What should those consist of? Certainly blood pressure examination, lipids, blood glucose, and others. And it's important in these patients to, as you monitor them, to keep an eye on them to prevent diabetes, as well as other cardiovascular disease issues that may arise with ADT. And so, again, when you start these drugs, and especially with, it was noted with that Abiraterone, that we want to routinely evaluate these patients before we begin these drugs. So last slide, how can we avoid some of these side effects? In the past, we've always been told, based on older data, that estrogens are not useful in prostate cancer because of the side effects. But this was a trial that was recently done looking at an estradiol patch. And what they found was that they had a comparable castration rate to LHRH agonists. And the risk of cardiovascular events or sudden death were low. Part of the reason that this is different than estrogens in the past is this is transdermal application, so you don't get that liver pass-through that you do with oral utilization. So this might be something coming up in the future. Gynecomastia was a side effect with these patients, however. So take-home points include combining androgen deprivation therapy and androgen signaling inhibitors and docetaxel are now standard of care in patients with androgen deprivation therapy. These drugs are androgen receptor signaling inhibitors, and again, you want to consider those in patients who can't tolerate systemic steroids. Abiraterone is an androgen synthesis inhibitor, and it's preferred in patients with seizure history, severe baseline fatigue, or on Coumadin, in that we really have to be careful in these patients receiving ADT and screening for side effects, treating these, and especially with regard to cardiovascular side effects, it's very important. So I will stop there and introduce the next speaker, that is Dr. Lenny Gomella. He'll be talking on the genetic testing in advanced prostate cancer.